Welcome to the Village Talks. This is a space where physiology meets lived experience, where we talk honestly about the body, the nervous system, relationships, and the real questions families are asking without fear-based narratives or a one-size-fits-all answer. We're your hosts. I'm Dr. Jaimy.
And I'm Dr. Brittany. We're chiropractors, perinatal specialists, and humans who work closely with families through preconception, pregnancy, birth, postpartum, and early parenthood. Whether you're preparing for pregnancy, currently pregnant, newly postpartum, raising a little one, or supporting someone who is, you're in the right place.
Let's get into today's conversation.
Hello, everyone. Welcome to today's episode of our podcast. Today, we are doing an introduction to breech positioning for babes. This is a very nuanced conversation. It's a very big topic. We have lots of opinions about it. So we're just going to touch base on a couple key factors and then expand from there in later episodes.
Yeah, I would say breech is an area of passion for me,
Yes.
Given my own pregnancy and birth experience. But I think breech positioning is something a lot of people aren't aware of or give no thought to until they're told baby's breech. And you're like, what does that mean?
Yeah.
So, just breech position is where baby's head is higher than baby's butt. So when we think about if you've ever seen sort of like a map or what am I trying to say? Like a diagram of what baby's development looks like. And in those early developmental photos or diagrams, baby's head is up. And then there's a point where now baby's head is down, right? And so breech is normal until it's not, right? Developmentally, babies are going to grow with the head at the top, and then we hit a point where based on the size and the weight of their giant heads in relation to the rest of their skinny little bodies, combined with gravity, with mom's center of gravity, with the fact that they're floating in amniotic fluid, eventually the gravity and the weight of the head are going to shift so that now baby's head is lower than baby's butt. Breech for the longest time was considered a variation of normal, and really wasn't treated any differently in leading up to birth, though it always certainly was treated with a little bit more care and attention during birth. But now in this country, breech is not really considered a variation of normal. Most providers are not trained in the considerations and nuances of breech birth. And so if you find out at usually, 35, 36, 37 weeks that your baby is breech, in the U.S., you are told we are going to go ahead and schedule your C-section. So I think the goal for me is just education. Is informing parents that breech is a possibility, that we actually want to be paying attention to baby's position earlier than 36 weeks. Baby's position is considered unstable to that point. That's why most people aren't checking until that point. So fair enough. We are not asking anybody to predict where your baby will be when you go into labor, but we do want to watch baby's patterns. And we do know that there is a normal time frame for when we expect baby to go head down, and that's usually between 28 and 30 weeks, up to like 32, 34, like there is this range. And so if you are getting an ultrasound, people like, oh, my baby was breech at 20 weeks. Most of them are not concerned at all.
And that's what we mean by unstable too, right? It's not pathological or anything like that, and nothing big and scary. Unstable as in they have lots of space, they're smaller, they can move around, hopefully.
Absolutely. And they shouldn't be settling into their final position at 30, 32 weeks. That's also not ideal. They do need to be moving around and stretching as they're growing. And so if baby's breech at 28, 30 weeks, 32 weeks, okay, we're not concerned about this. This is just a snapshot of where your baby is in this moment. And if babies are really active and you're really comfortable, we don't need to think any more about it. But if you feel like there's a whole lot of pressure where this baby's head is, or I feel I only get movement in this one area, then we're a little bit more inclined to think that there might be some restrictions or there might be some tension in tissues that are resulting in what you're experiencing in your body.
Start our Nancy Drew discovery of what's going on.
And it might have an impact on where your baby is as well.
Yeah.
So this, when we have babies who are known to be breech in early third trimester, you can do some forward leaning inversions. You can do some side lying releases. You can, go swimming, do some like there's so much stuff that you can do that is good for your body and releasing tension anyway.
Yeah.
And that gives us the opportunity, hopefully, to create a little bit of space and see now if baby is going to get into the position that we expect them to.
Yeah, and those movements, I would say, are different than movements that we would recommend to help engage baby into the pelvis, right? So those look a little different as well, I would say, in our practice, specifically of how we kind of guide our clients and our patients of like, oh, okay, like here are some things that you can do that can kind of help give more space. Maybe avoid some of these things for now until we know where baby's positioning is. If they are in more of that head down, stable position, great. Now we can kind of transition into some other things.
Yeah, and I think I typically encourage patients, I'm like, if you have a visit with your care provider, between 30 and 34 weeks, ask them if they can manually check and see where a baby is. We don't need to be doing ultrasounds at every visit and confirming. But it's, somebody with a skilled set of hands that is making an educated guess based on what they feel about where your baby might be. And they're still pretty skinny at that point. So sometimes heads feel like butts and butts feel like heads.
Oh my gosh, yeah.
And it's really hard to tell, but it's a guess, right? And the more sets of hands that we have guessing, the higher the likelihood we're going to catch if over this course of a couple of weeks, it becomes evident that baby's not in a great position and they're not changing their position, right? If you're breech one week and head down the next, and then they're sideways, and then their head's on the other side, and then they're like, they've got room, right? Like they're exploring, they're figuring it out. We know that they have space. We don't need to be worried about it. But if we do get to that 34-week mark and baby's pretty consistently stayed breech despite doing some of these really simple movements at home, then that's where we have the opportunity to add things to this equation. For us, of course, it's Webster chiropractic care, acupuncture and moxibustion, being really intentional about what are we doing, what are we not doing, being really mindful of posture, actively, consistently getting into these positions. They're going to reduce tension on these tissues so that hopefully by the time you get to that 36-week ultrasound where they are expecting baby's position to be stable, that's a head down position.
And that's if you want it, right? We're not saying you absolutely have to do any of this stuff. We discussed it before this podcast episode of a lot of our clients that why we're doing this thing is because they would like the opportunity to give baby space to go head down. So we have these things in place to be able to support them, and we're not manually flipping baby with our hands. Chiropractors don't flip babies. Hey. Can we give baby more space and opportunity to go head down by creating more space in mom's pelvis and rib cage, abdomen, all that? Absolutely. Great. But we are not manually doing that ourselves.
Absolutely not. And I think it's sort of like escalating levels of intervention, right? Because where we're starting in the early 30 weeks is you do some stuff at home. Right? And then if they're still not head down, then you get body workers involved. Right? And then if we haven't moved through those two phases or we haven't, baby still not head down, then there's the potential for the external cephalic version, which is manually flipping the baby, which is only done in a controlled hospital setting with an OB, a skilled OB. And then, the last level of intervention here is typically going to be C-section. So, for patients who are finding out at 36 weeks that their baby is breech and they're scheduled for a C-section, they're like, all right, cool. We don't see them, right? Like they're not coming and looking for our low-level intervention to try to facilitate baby.
But they do come to us to help with recovery too.
Absolutely. But I think in terms of what we typically see are the people who are hoping for and planning for a vaginal birth,
Yeah.
right?
Yeah.
And for the most part, in order to be eligible for that, in most of the country, your baby has to be head down.
Yeah.
There are skilled breech providers out there, but they are few.
Yeah.
And there's often a lot of distance between them.
Yeah.
And so the option to try for a vaginal breech birth is not on the table for a lot of people. And
Yeah.
so if they are not comfortable with moving into C-section or not comfortable with the ECV, they are looking for alternatives to help assist baby getting into that position.
Yeah.
That's typically who we're dealing with.
Yeah.
And so for us, it 36 weeks isn't too late, but babies are bigger and longer and have less space than they did at 35, and then they did at 34, and then they did at 33. So sometimes we'll get calls where people are like, oh, I had a ultrasound at 26 weeks to check placenta position, for example, right? There's all these different reasons to have sort of interim ultrasounds, and they said baby's breech, and they're stressed out about it. I'm like, oh, you don't have to be stressed at 26 weeks. Like, I'm glad we know.
Yeah.
And like, here's some really simple stuff you can do at home, right?
Yep.
Like, we don't want to be stressing out about this point, but we also don't want to be completely ignoring everything up until 36, 37 weeks, because now the time and the options on the table, if you're not comfortable with diving into a planned C-section, those options are now more limited.
Yeah.
And so that's kind of our goal, is just information, education, understand what is considered optimal fetal position. Posterior positioning and asynclitic those are different conversations, but sort of what is considered normal, because you also don't want to find out at 38 or 39 weeks when baby's head is engaged that, oh wait, this actually isn't great. And baby's position is a huge impact on the length of your labor, and the difficulties that you may experience during labor, stalls and things like that. So we just want parents to have the information to understand how things along the way have the potential to impact their options for birth.
Definitely.
Get your provider involved. Ask them, where's baby today? And then where's baby at the next visit? And then we're just seeing, like, what is this baby up to? Are they in a good spot? Great. Are they not? What can we do about it? And at what point are we introducing these potentially increasing levels of intervention to try to get this baby into a head down position?
Yeah. And I would say, why we're so passionate about this too is because it breaks my heart every time we get a phone call. We get a lot of them of panic, sheer panic. I just had my 36 weeks ultrasound. My baby is breech. Nobody, like, my provider didn't talk to me about it. My options were like, baby's breech. Okay, here are your options. ECV next week at 37, or we have a C-section. If your ECV doesn't go well and sends baby into distress, then we're going to have an emergency C-section. Those are your options. Great. And that's what they're left with. And they call us in a panic, and it breaks my heart, because was baby breech earlier? Did we know position earlier? Because there, like you've been saying, there are some really great things that we can start early on. There are some really great things that we can do that are non-invasive interventions prior to that 36-week ultrasound.
And there are often signs that baby is breech aside from confirmation via ultrasound. So I do think that for the patients who are finding out at 36 weeks and are coming in a panic, as we talk to them and we try to do a little bit of detective work and get some background information, there are some things that we see really consistently. So when we have a head in the top half of the uterus and the abdominal cavity, it is uncomfortable. Babies do not fit as well head up as they do head down in terms of organ placement. So, oftentimes these parents are experiencing a lot of heartburn. There's a lot of discomfort and fullness after eating small meals. There is a lot of pressure in the top part. They're experiencing more rib pain and discomfort.
Yeah, transverse abdominis gets like a little overstretched and too much pressure, that like burny sensation they get in the muscle.
We'll start, like, that's not 100%. But I will say that we hear that a lot more consistently when babies are breech than we do when babies have gone head down by 32 to 34 weeks.
Just different sensations.
We hear a lot less oh, there's so much pressure. Oh, I can feel baby's head against my pubic bone. I'm starting to waddle. We don't hear that when babies are breech at 36 weeks. So these are just little clues. And so I think if parents have this information and they know to ask, because most times they don't know to ask. And sometimes it's like, is your provider putting two hands on your belly? Yes. They are checking baby's position, right? Like, they don't need two hands to check baby's heart rate. So yes, they're measuring your belly. Yes, they're checking baby's heart rate. If there's two hands on the belly, they're checking baby's position. Ask. I will hear people say, oh, my provider said they're not worried about it. I'm like, I'm not worried about it either. And you don't need to worry about it. But it is a valuable piece of information that has the potential to impact the things that are possible for you in your birth. And most people, given that information, would choose to act sooner. And we want that option on the table for them. As I said, there are plenty of people who don't act sooner and are not concerned about it and are fine with their options becoming limited as that process unfolds. Those are not the people we're dealing with, right? We are really very consistently hearing, I wish that somebody had checked sooner. I wish that I'd known sooner. I wish that I could have started this 2 weeks ago, 4 weeks ago, whatever. So that's really my goal with today's topic is, here's what you should be asking and when. Because if you want to have options on the table, the options are becoming limited with each passing week. And here's the time frame to be looking at these different possibilities in the hope that everything up to the ECV is assisting your baby and your body in creating more space, either releasing them from where they're locked into or opening and creating space where they're trying to go. And that's a non-invasive process that baby completes on their own up to the point of the ECV, which is usually 37 weeks, right? So there's not a lot of time. It's not the whole pregnancy, but it's usually months, if not at least a couple of weeks, where we can do some really gentle stuff to try to help baby get into that what is absolutely considered a more favorable position for birth.
Absolutely. Yep. And the other thing I like to talk about with our clients and with our patients is, it's nothing you did wrong. Baby is in this position for a lot of factors, and you didn't do anything wrong prior to getting pregnant. You didn't do anything wrong in your pregnancy. There are just factors that we have to look out for, patterning in your own system that happened prior to that we weren't aware of, blah, blah, all that stuff, right? It's the minute, not for everybody, but I see a lot of it, but the minute we hear baby's breech, I've seen a lot of our clients go into, oh my God, what did I do wrong? Is this going to affect my baby long term? This isn't the birth I wanted. How could I let this happen? Like we kind of go into this spiral, and that's not great for us either.
There's a lot of self-blame. And optimal fetal positioning is so nuanced, right? There isn't any one thing. We have both experienced cases of like, there was one thing that happened and then baby went breech, or there was one thing that so it can feel like it's one thing. And it isn't only physiological. So I do think it's not because you've done anything wrong, but it's life. Right? I mean, my first pregnancy was very much a case of like, knowing what I know and doing what I do, I thought I was doing all of the things to make sure that my baby was in optimal fetal position. So it's a real eye-opener when you find out 38 weeks that your baby is not head down. And 100% had been there the whole time.
You know if their head, if that has been their head the whole time.
So at 37 weeks, I saw the most experienced midwife on staff, and she was like, here's baby's head, like, yay. And then the 38 weeks, I saw a brand new midwife, not only new to the practice, but new to midwifery, and was like, I don't think this is a butt. And I was like, what do you know? Right? Like, the other midwife said it was a head. And, and so, that was an interesting experience, but people can very, very, very quickly spiral.
Yep.
Especially if they had some knowledge and they did feel like they were doing everything right.
Yeah.
And so this is where sometimes something that's a little bit more individualized is really beneficial, because there's all these things out there that are great for pregnancy, right? We talk about this in our yoga classes. Like, everything that happens in this class is safe for you and your baby, but it might not feel good in your body, or it might not be good for you today based on what is happening, right? So there's that consideration too. You can do everything right, but one, these babies have instincts too. Them going head down is an instinct for them, and that not happening can be because they know something we don't know. There's all these physiological factors for birth that, you know, you can have a septum in your uterus can be uniquely shaped. Your placenta, fibroids. You can have fibroids, your placenta could be in the way, the cord can be short, the cord can be wrapped. Like, there's all these things that none of these early low intervention things are going to make a difference. So I think that some of this comes down to peace of mind, right? And sometimes that's even the conversation that where patients come in, they're like, I just want to do everything I can. And if baby doesn't turn, they don't turn. But I know that I've given them the best chance. I've controlled what I can control. And if there is something, I don't want to not do it and then wonder if it could have helped. I think, you know, I've seen some interesting and unique cases over the years with things where later we were like, oh, he was almost 13 pounds. That's why he didn't turn. Oh, you had like a 27-inch long umbilical cord and they were in there like Tangled. A marionette, you know, like those are not super common, but no amount of body work is going to overcome that.
That's why I always tell her when people come in for their initial visit specifically for breech, one of the main things that I touch on is I say, baby has the inside scoop that we don't. So there are lots of things that we're going to do, and hopefully it helps. I know for a fact that you're going to feel better in your pregnancy, even if baby doesn't flip. But there are things that we just, even with an ultrasound, we can't see and we're not aware of. And it doesn't have to even be this big crazy thing of a fibroid taking up more space or the cord, whatever. Like, there are things that babies are way more in tune with than we are, and that's okay too.
And more often than not, when they stay breech, we don't really know why. We don't get those answers. But the majority of it is why we see such a high success rate in the office when we are working on optimal fetal position, because for the most part, those physiological barriers are pretty rare. Right? More often than not, we do find some tension or some rotation patterns or some compensation patterns that are creating these potential internal obstacles for baby, right? Internal to us, but this is all external to the baby, and it's impacting the space in which they have to maneuver and navigate inside the body. So, you know, I think I've never come across a person who, you know, we find a pattern or we find a tension, we find an issue and say, I think this is impacting your baby's ability to move. And they're like, nah, I don't care. I'm not going to do anything about it, right? I do think most moms want to create softness and suppleness and remove those obstacles and hope that it helps baby to get there. So there really shouldn't be any self-blame, but if you're interested in seeing what you can do and you're interested in keeping options on the table and keeping things wide open, this is one of the things that you should be asking about and understanding as your pregnancy progresses and as it approaches birth, because it is a factor that means very little until it is now the determining factor in how your birth is going to go.
Absolutely.
And
just like anything, right? We love education, giving our clients and people their power back into their decision making, because that's another conversation for another time. But why we recommend seeing people a little bit earlier, right? Like, you don't have to have anything wrong. You don't have to have pain. You don't have to have discomfort. You can just come in for some prenatal wellness, which we love. And we want to just take care of you in this pregnancy because you deserve it. And then same for postpartum too. But what's nice is if we start sooner, then we can walk you through this type of stuff if we ask about how was your OB appointment? What did we learn? How was your midwife appointment? What do we know? All that kind of stuff. And when you're getting this work done regularly early anyways, we have a pretty good chance of not having like that big scary ultrasound at 36 weeks majority of the time. Now, sometimes we have clients who have been with us and their baby last minute decided to turn breech, and that was their experience, and they ended up having C-section, and it happens. But we also liked them to know what their options are as well when it comes to early intervention. And then also too, where are you? There's Breech Without Borders that you can look up breech providers where you live and see if any are available, if that's something you want to explore. And then I know for Dr. Hall, who does it here in Denver, you go through a screening process first to see if you're a good candidate for breech delivery. So there are people who do want to walk down that road to see if it's a possibility, and others who don't. And that's okay too. But at least you know what your options are, and it was your decision, not anybody else's for the most part.
Yeah, and I think, what I've told some of my patients who've been through this experience, and one of the things that I think for me personally was really valuable was I knew going into labor that the possibility of needing a high level of intervention and having a C-section was significantly higher than it perhaps would have been with a head down baby. So, I went from my baby's head down, I'm going to have this really low intervention breech birth, to now I've risked out, I'm going to the hospital, I need to deliver in the OR, I need to be monitored. Like it was a 180 degrees almost from where I thought I started. So I had 2 weeks to process a lot of the emotions. I had time to accept the fact that this was no longer possible and start asking questions about what was possible in the birth that I was going to have. And I think that time was really valuable. And so I think that's something that people who are surprised with this positional, shift, they process a lot of their emotions before birth. Even if baby goes head down. Even if the ECV works, even if, right? Like if at any point from finding out baby's breech to giving birth, baby goes head down, their postpartum experiences and recoveries are often really different. And I think that's part of it, is they've sort of been forced to process possibilities and think about things that they did not think were on the table in a very real way, compared to the like, well, that's always possible. Well, that could happen. All of a sudden it's in your face of, this is going to happen. And then if it doesn't, that's awesome. But if we have 4 full weeks to process this, or we have time to explore our options and really decide how we feel about all these different things, there's a little bit of an advantage to that. And so when you start thinking about those things sooner, and you start having conversations with providers about what might happen, mentally, I think there's a big advantage to that going into birth, regardless of what that looks like.
Absolutely. Is there anything else you would want, just as like this is our touch point on breech, let's talk about breech, baby, but anything that you think, like from today's episode, like what do you want them to know?
I think I really just want people to be curious about where their babies are and what their babies are doing, and if there's any information to be gleaned from that we can act on, right? Like I always say, I got into this work for prevention, right? For preventive care. I became a chiropractor because I have had headaches for almost my entire life. And getting regular chiropractic care was the only thing that ever prevented me from getting headaches. So from a preventive perspective of it's possible. Don't stress about it. But it is one thing that you should be asking and one question that should be top of mind, because there is a timeline and there is an expectation that baby will be here at a certain point. And if they're not, then things are being pulled off the list of possibilities for you. So I think it's just understand that baby's position is important before birth. And if having a lot of options for birth is important to you, then you should be asking this question perhaps sooner than the information is being provided to you naturally by your provider, right? So, asking at 32, asking at 34, information is power. Yeah. And so it doesn't have to change any actions that you take. But I don't want anybody, we do really feel for the people calling in a panic at 36 weeks because we know that the things that worked 2 weeks ago are less likely to work now, right? Webster is highly successful for encouraging optimal fetal positioning and creating space for baby, but the success rates at 34 weeks are like 25% higher than they are at 36 weeks, right? And Webster still has better statistics than the ECV at week 37. So I say it's never too late. That baby's on the inside is not too late. But most babies are not turning on their own at 40 weeks. There is not a lot of space left for them to do that.
Although we did have one. Oh my gosh.
I've had more than one.
Well, I mean, this year. I said this year we had one where baby was head down the entire time. Baby flipped at like 38 weeks and she wanted to have a home birth and all this stuff. And she went in for her ECV. Baby was head down. And then she was able to have a home birth at 40 weeks. And it was just this roller coaster of emotions. But she has familial history. Her grandma, her mom, and her sister, like they were all breech and then flipped at the last minute. And we're like, okay, we're ready now. And so like it can happen. It's not impossible. But it totally can happen, and sometimes it doesn't.
And some people are okay, like, I'm going to let this process unfold. I think I've seen this conversation come up, specifically conversations with people in the birth world speaking to breech specifically, where it's like, you shouldn't do anything to intervene, baby is just going to be where they need to be. And I'm like, if you have access to a breech provider, great. Absolutely. Let this unfold as it's going to unfold. But if you don't want to have a C-section and that is the only option available to you, doing low intervention things that have other benefits. Everybody sleeps better after they get adjusted. Everybody feels better in their body after they get adjusted. Like even the patients whose babies don't turn, they're like, but this is the best I felt my whole pregnancy. So there are other benefits as well. I think there are a lot of factors. So just to say we shouldn't ever do anything to encourage optimal fetal position, I can't get on board with that.
I can't either.
I'm not on board with every single person getting an ECV every single time either, right? Like it is very nuanced. And I think for people who want to and are willing to explore these really natural things that not only have little to no side effects, but also have additional benefits. We of course think everybody should be getting adjusted in pregnancy anyway. But to not offer it up to people as an option, to not educate them on the things where if they are trying to take charge, and do something to reduce the possibility of C-section, to withhold that from them also to me feels irresponsible, right? It's information, it's education. Let them make the choices for themselves. What are they willing and able to do? I would say trying to turn a breech baby is like a full-time job, right? Between if you're seeing us, if you're getting moxibustion, seeing an acupuncturist, if you're doing any other kind of body work, and then how many inversions are we doing a day, and then I got to go to the pool and I got to do headstands, like it's a lot. So not everybody has the time or money or capacity to do all those things.
Totally.
So it's like give them the information and let them choose.
Like we have a handout that we give them of other things that they can be doing as well.
What, if anything, do they want to do?
Exactly.
Obviously, for us, everybody coming in is looking to do something. And so we just want to give them, here's all your options, and we are here to support you with as many or as few of these as you want to try.
And I think what I want everyone to know too is if we're in more of like an OB setting, or you're with a midwife who believes that you should just not try anything and this is where they need to be, I would say don't necessarily take their word for it when they say like, well, there's no research to show that like doing all of this other stuff is going to actually make any change. I would say they're not really trained in those things.
Yeah.
We are.
Yeah.
We're trained specifically in what chiropractic does.
Yep.
We work in collaboration with acupuncturists.
Yep.
We have massage therapists who can release tissues that where we've seen all of these things come together. We have people who are training spinning babies. We understand spinning babies. We use dynamic body balancing, which is where it came from. And so there are these factors where like anecdotally, yeah, we see it work really well in practice, and research takes time. Research takes a lot of money. Research takes volunteers to be able to sign up and do this stuff. So don't necessarily just go off of like, well, my OB said there's no research, so it's not going to happen. Okay, with that mindset, most likely it's not going to happen. Yeah. But also too, if you're like, well, I want to explore my options, go for it. Don't just take their word for it. No offense to them at all. I think they're all really wonderful for the most part. However, their specialty and their training is one thing. Our specialty and our training is another thing. And go with people who know what they're talking about.
And the reality is double-blind placebo studies don't exist for most things in pregnancy.
For women especially.
And so, you're not going to find a traditional research paper that proves that all this stuff works. But there's a lot of clinical evidence. The ICPA has research papers showing, outcomes. They've done numerous Webster studies and Breech studies. And so there's actually a ton of evidence. There's not a ton of research. And I think if you hear that and you're like, yeah, I think that's probably true. Okay. Then this path is not for you, and that's okay. But I think if you're being told that and you were like, that doesn't sit well with me, I'm pretty sure there's some stuff I can do, then follow that instinct and explore. And we get referrals all the time from OBs and midwives and birth workers who know that this works. And, I've had other patients come in who are like, well, this person said not to do it, or this person said don't bother, or this person, and they decided to explore it anyway. And sometimes they come back and they're like, my provider couldn't believe this worked, and now they're going to consider it. And I'm like, great. It means they're giving their patients more options. And I think that's, if things are safe, because at the end of the day, Webster Chiropractic is absolutely safe. All of the body work around optimal fetal position, when done by a trained and experienced provider, is safe. We can't guarantee efficacy. We can't guarantee outcomes. But if you're open to exploring it, here are some of the things that are available to you.
We've got you. We're here for you.
And, if it's here in Denver, awesome. Come see us.
Please.
I, personally love Breech. And if you're not local, you can find Webster certified chiropractors on the ICPA website. Breech Without Borders has a great list. For local regions and Breech supported providers.
You can drop it in the comments, and we have people that we love and trust in different areas that we can kind of guide you towards.
Yeah, there's options. If you're looking for them.
Love it. Yay. Love Breech. Such a fun conversation. I just like people that have options. Sometimes you get analysis paralysis. I get it. But it's also nice in this situation where you're like, I can breathe because I know it's available to me. Awesome. Love it.
And I think for a lot of parents, when they get that news, it's extremely, like we talked about, they feel shame, they feel guilt, they feel, but there is also a huge sense of a loss of control. And we know we're not in control, but there's still a little bit of a perception of control. And then all of a sudden they have no control. And things are changing very quickly. And so doing things like this can help you feel not that you have control over the situation, but you are doing something to hopefully move you towards this outcome. And that's empowering. So while you're not in control, you do feel empowered to do something, to make choices. That can be a huge mindset shift, an emotional shift
for sure
for people who suddenly feel like I have no options, and it's not it's not mindless. It's mindful options.
Snaps.
It's not just, let me just do something, do anything, or throw my money or my time at this. No. Like we see, for the most part, we see really positive outcomes and high success rates. So this is a very intentional, these are all very intentional things that you can do, so that you're not spiraling and spinning and feeling like you have no hope and no control over this situation.
Absolutely. Yep. I love it. All right, cool. Well, that wraps up our conversation today about the touch points on breech, but we will definitely get into a deeper dive. I want to prepare everyone. Dr. Jaime's going to share her birth story coming up soon, about what a vaginal breech delivery looks like and feels like and all the nuances, which is really fun. So until next time, thanks for listening. If you have any questions, drop them in the comments as always. We'll look at them and answer them as best we can. Thank you. If you found today's episode helpful, you can subscribe, share it with a friend, or leave a review. It helps this podcast reach the families who need it most. You can find us at Belly Bliss in Denver and online for resources, workshops, and support. Until next time, take care of your body and trust its wisdom.